Hi everybody. This is a 45 years old female patient who presented with right arm weakness. There's this obvious abnormality that's large and located in the left frontal convexity. It appears heterogeneous. The lesion is also surrounded by this dark rim that represents edema, and the question is this vasogenic or cytotoxic edema? We discussed previously that cytotoxic edema is one of the things that are very commonly seen and is typically associated with infarcts, while vasogenic edema is typically associated with neoplasms, infections, and hemorrhage. We also discussed that on a normal CT scan, the cortex or gray matter appears white, while the white matter appears dark. That's normal. The main feature of cytotoxic edema is that you have cell death and you lose the cortex white matter differentiation. So the gray-white matter junction would be lost with cytotoxic edema. That's not the case with vasogenic edema. Despite this large heterogeneous central lesion and despite the surrounding edema, you could see that the cortex is preserved. Since the gray-white matter junction is not lost, this represents vasogenic edema. Now we're thinking neoplasm infection or hemorrhage. Hemorrhage is less likely, especially in the acute phase, since acute hemorrhage would appear bright. It's not the case here. Another concept that we talked about is lesions within the brain are intraaxial, lesions within the skull but outside the brain are extraaxial. And this lesion here is clearly centered within the brain and has other features that go with an intraaxial abnormality. So this is inside the brain parenchyma. Adjusting the window, looking carefully, you'll notice that you have another focus of hypodensity here that does not lead to loss of the gray-white matter junction. Now, just by that, you're suspecting multifocality of at least two intraaxial lesions. You have to look more carefully. Since both neoplasms, such as metastases or infections of various causes, could have multifocality, let's look carefully. We've talked before about how the surface of the brain is undulating, with these being gyri and these being sulci. Since a deep sulcus contains CSF fluid, which appears dark here, comparing the sulci on each side would be a useful thing to do on this case. And if you do that here, you'll notice that you have abundance of dark sulci with CSF, except for this region. It's a tough call, but if you look carefully, you'll notice that there is a density here that's very close in color to the adjacent cortex. It seems to be centered on the sulcus, may be attached to the falx, and is not associated with edema. If this lesion were to be true, all these features would suggest an extraaxial location. So if this is true and you have multiple intraaxial lesions as well, the combo of intra and extraaxial lesions should raise the possibility of metastasis. At this point, to complete the evaluation, you have the options of giving intravenous contrast and doing another CT, or doing an MRI with contrast. The radiologist doing the case that day elected to give contrast and image the patient with CT after. So this is the CT with contrast. This is your first lesion. It's large, heterogeneous, and enhancing, telling you that it's hypervascular. It's even more obvious that the other focus here also has a central hypervascular lesion. Not only that, if you look more carefully, you'll notice other foci of intraaxial enhancing abnormalities, such as this one here and this. Another lesion is here, adjacent to the temporal horn of the lateral ventricle. All of those lesions were more difficult to see without contrast. And the lesion that we suspected to be extraaxial and attached to the falx is actually present and hypervascular as well. This has a good teaching point, since extraaxial lesions in comparison to intraaxial ones are usually associated with no or minimal edema. Looking more carefully, you'll notice other areas of extraaxial enhancement, such as the sulcal enhancing region and this one here. So now you confirmed that these are not hemorrhage or infarcts. They're multifocal hypervascular intra and extraaxial lesions. The most likely diagnosis is metastasis. And this turned out to be metastasis from a primary breast carcinoma. So this was a quick case, first of all, to emphasize looking carefully at the brain symmetry to make sure you don't have any intra or extraaxial lesions, and look carefully at the sulci, make sure nothing is filling them. It's also a good case to review some features differentiating intra from extraaxial lesions, and to discuss a little bit about vasogenic versus cytotoxic edema. Cytotoxic is commonly infarcts, vasogenic is commonly neoplasm infection or hemorrhage. Multifocality and a combination of intra and extraaxial lesions raises the possibility of metastasis as the first choice of differential. And we also learned that metastatic lesions could be missed on a CT without contrast. So if you're suspecting small metastatic deposits, you'd better do an MRI with contrast or at least a CT with contrast. Thanks for watching, and see you with more cases later. Hi again. This is a case that's extremely interesting for radiology residents. Juniors would find this useful as well. So this is a chest CT with contrast on a 76-year-old male patient who has left chest pain. I'll give you a chance to look at the examination. Here's another quick look. The difference between the normal right lung and the totally abnormal left lung is obvious. The left lung is small. The left lung also shows this heterogeneous, distorted appearance. The main findings are the presence of these peripheral pleural-based calcifications. The calcifications are very dense. They circumferentially surround the involved area of the lung. And this area of pleural abnormality has fluid contained within the center. So measuring these areas here would give you fluid density. The features that you see here are consistent with a chronic pleural abnormality that contains internal fluid. The heterogeneous appearance here is actually the compressed, diseased, and distorted lung. Look at how the lung is distorted at the apex here. There is some aeration anteriorly. Now, such a diseased pleura that's relatively thick and calcific with adjacent lung distortion is consistent with what's called a calcific fibrothorax. So you have pleural thickening and calcification, lung distortion, associated fibrotic changes, and volume loss. A calcific fibrothorax is a result of a previous insult, commonly a previous granulomatous infection. The commonest reason to see a calcified fibrothorax is all tuberculous infection, and here you have evidence of that in the form of a calcified granuloma. Now that we cleared that out of the way, let's look at the fluid collection within the pleura here. You notice that you have these air bubbles within the fluid collection. And this is a finding that needs explanation. It's not normal to see air within the pleural space, even if you have a pleural effusion or collection. One of the common reasons for seeing fluid within the pleural space is a recent intervention, such as pleural tapping or draining. Another reason would be trauma with the presence of pneumothorax on top of a fluid collection. A third, less likely and theoretical reason would be gas-forming organism. However, none of these reasons were present in this case. And that leads us to the final cause. There should be a communication between the airways and the pleural space. This could easily happen with diseased lungs from various causes such as infections, and this is what we call a bronchopleural fistula. Depending on the size of the airway communication, sometimes this may be seen on CT. However, in many times it's usually difficult. Now, in addition to the patient's chest pain, on questioning, the patient stated recurrent infections, which is an expected complication of a bronchopleural fistula, and this could explain the air and fluid within the pleural collection. If that's the case, this is what you could call a chronic empyema or a pyothorax. So an infected pleural collection is an empyema, or pus within the hemithorax is called a pyothorax. That explains the name. And here we come to a very crucial point. Whenever you see pleural thickening, please assess the thickening very carefully. Note that the timing of acquiring the CT after giving contrast is important. When the timing is more arterial, such as what we see here, enhancement of the pleural space is difficult to detect. Enhancement of the serosal surfaces, such as the pleura, is better appreciated when you take an image at a delayed acquisition, such as a portovenous phase. Despite that fact, you still have to assess the pleura very carefully and try to change the window so it could differentiate between fluid and soft tissue components. And if you do that and scroll all the way down, change the window a little bit more, you'll notice this. Here's the hypodense central fluid, and here's a very thick rim of pleural involvement. Looking more carefully at this, you'll notice that there is this soft tissue component that extends through the intercostal space between the ribs and invades the chest wall. Let's go over this even more slowly. You'll see that this is a very thick soft tissue abnormality that's related to the pleura and extends outwards. Thickening of the pleura that is more than 1 centimeter or that invades adjacent structures is a sign of malignancy. So this is something that we should not take lightly. We should assess the pleural thickening very carefully, and if you see something like this, you should alert the clinician. On biopsy, this turned out to be lymphoma. You might think that this is a patient who is unlucky, who has all these pleural abnormalities with superimposed lymphoma. However, we know now that this patient has chronic empyema with recurrent infections of his left hemithorax. And this is actually a rare but well-known entity known as pyothorax-associated lymphoma. The reason for this happening is unclear, but the theory is that the persistent or recurrent infection within the chest or pleura leads to development of neoplasm. So the final diagnosis here is a calcific fibrothorax with a bronchopleural fistula leading to pyothorax-associated lymphoma. We learned a few things today. First of all tuberculosis is a known cause of calcific fibrothorax. We also learned that there are a few causes for the presence of air within a fluid collection. If it's not iatrogenic, traumatic, related to infection, make sure there is no bronchopleural fistula. We also emphasized the fact that enhancement of the pleura is better seen on a delayed portovenous phase. Yet it's important to look at the pleura very carefully. Any thickening more than 1 centimeter or that invades the chest wall is suggestive of malignancy. And finally, we talked a little bit about this rare yet well-described entity of pyothorax-associated lymphoma. Thanks for watching. Your comments are appreciated as usual, and we'll see you with more cases later.